Awesome. Good morning, everybody. My name is Mira Singhvi. I'm one of the hospitalists here. It is my great pleasure and honor to welcome Dr. Gill here from Nemours Children's Health. I met Dr. Gill a couple years ago at a PHM conference. I attended one of her workshops on medical child abuse and instantly knew that we had to bring her here just to help us navigate this complex world. For a little bit of background, Dr. Bex Gill is a recognized expert in medical child abuse and Munchausen by proxy. She's presented her knowledge at prestigious conferences across the country. She's a recurring contributor to the acclaimed podcast, Nobody Should Believe Me, which delves into compelling cases of medical child abuse and has garnered a very significant following. She's passionate about spreading her awareness of medical child abuse, and she actively advocates for her victims and survivors through various initiatives, including the Munchausen. She's a board member of the nonprofit organization Munchausen Support and a member of the APSAC National Subcommittee of Munchausen by Proxy. Please join me in welcoming her for our grand rounds today.
Hi, everybody. Good morning. I am very appreciative to Mira for reaching out and for inviting me here. It sounds like your hospital is very open to this. They want to talk about this, and I'm so excited to be here. I actually spoke at Banner Health in October, I believe, and I was out here in Phoenix and talked to a lot of them. So my hope is maybe in talking to both of the big kind of children's facilities here that even, inter-institutional, you guys can do better, and communicate more, knowing all of you kind of have heard about it and learned about it. I do not have anything to disclose. As Mira said, I am on the podcast about this abuse, but it's not anything to disclose. These are my learning objectives, and I hope I get through them today. Like Mira said, I've actually been at Nemours Children's Hospital in Orlando since it opened, like on opening day in 2013. So I'm going on 13 years, which is hard to believe. I moved around a lot as a kid, so staying in one institution is kind of very foreign to me, but it turns out when you have kids and they get attached to their schools and everybody becomes like family, you just kind of stay. Because of a case I had in 2022, that was kind of the sentinel case for me, the one that really changed everything. I reached out to Andrea Dunlop, who's the host of the podcast, Nobody Should Believe Me, because it was really the only thing out there that made me feel like somebody else understands this or like I'm not going crazy. And I ended up getting in touch with her and other people. And then for anyone who watched the Take Care of Maya movie documentary on Netflix, that happened right down the road in Tampa. And she was actually supposed to be transferred to Nemours. And so again, it touched in Florida, it touched kind of nationwide, anyone who's aware of it. And as a result, I ended up covering that case on the podcast, and kind of the rest is history, I guess we will say. I've been going to national conferences. I have submissions to the international conference in Australia, which anyone who loves this kind of work, they go to very exciting cities all over the world for their conferences. Last year it was in Lithuania. I'm like, how did I miss that? When would I ever get a chance, to go to Lithuania? But my life is really my two boys, Crosby and Brecken, who I said in my last talk, I think they know more about Munchausen by proxy than Minecraft, because they listen to me and they're like, Mom, is that mom? I feel bad saying this, a munchie mom, or like and I'm like, guys, no. But they're wonderful, and they're why I do all of this. I know you guys are all medical, so you probably know some of this, but one of the big things that we argue about quite a bit on all of these committees is what it should actually be called. Honestly, I think I feel a little bit differently even than the current thought process, but caregiver fabricated illness in a child is what we diagnose the child with. So this is what AAP says is the diagnosis in the child. Factitious disorder imposed on another is what's in the DSM as what you would diagnose the mother or the perpetrator, the caregiver with. Munchausen syndrome by proxy is that tag word in the media. It's kind of the thing that maybe people that aren't even medical have heard. It's named after Baron von Munchausen, who was this German war general who came back from war and had all of these like outlandish, exaggerated stories. And so when this was first recognized, they realized it was kind of similar. These parents, or these, even when it's on self, come in with these outlandish stories, and that's why it was named that. even if we are going to use the word Munchausen by proxy, we choose to, we being like the people who kind of do this in our lives for some reason, we like to add abuse to the end only because it reiterates this is not just something that happens to people or to children. This is abuse. These children are being harmed. And so it just kind of carries a little bit more weight. And then recently we have decided that medical child abuse is the term. And the reason is it really focuses on, the harm that is coming to the child by the caregiver inducing, exaggerating, or fabricating these illnesses. And then the unnecessary and potentially harmful medical care is kind of how the child is then being harmed. After doing this work for the last couple of years, I've realized it is not just the medical system. These caregivers are manipulating the legal system. They're manipulating financial systems. They're manipulating community outreach systems, nonprofits that are dedicated to this, these different diseases. So this is almost like systemic child abuse. They are using these, fabricated, exaggerated stories to kind of use every system to both harm the child and really just kind of take resources and things away from others as well. You guys probably know a lot of these, but I think the truth is when students ask me, for instance, like, how do you know or when do you know? I think at some point there is an intentionality that comes to it. It's not just a mistake in reporting. It is an intentional formation of a story, where they have to kind of keep up the charade at some point and remember what they said to the last person. So they say the correct thing. They have to tell their child, we can't tell the doctors XYZ. So it starts to become this intentional process. They are moving cities, states, hospitals to keep this under wraps. And so that's not an accident. That is intentional. And then the inducing injury are the ones you're going to hear about probably in the media, the ones where they're injecting things into their PICC lines, the ones, where the child actually does pass away sometimes from that, sepsis from the PICC line infection or whatever it is. And the doctor shopping, just to point out this, people ask me this as well, like, doesn't every parent have a right to get a second opinion or a third opinion? Yes. I mean, I think that's how America runs. You do have a right to do that. I think the difference is this is not a caregiver who wants their child to be healthy and thriving, and they just want to hear they don't actually have this terrible thing, or, they want to make sure before they're going to undergo some extreme treatment, versus starting at a well-renowned children's hospital, moving on to maybe another hospital that has providers that will see children, to like the doctor who opens up their practice next to Albertsons and puts up a shingle and only specializes in this one condition. So they're almost doctor shopping to the most extreme, or to the non-board certified, neurosurgeon who specializes in this case, right? So it's kind of, it goes against what we think of as seeking opinions. If therapists, psychiatrists, social workers may see things a little bit different. These parents love referring to how unique their child is. Oh, they're such a zebra. They always keep the doctors guessing. They are quite resistant to therapy unless they find the therapist and they have identified them and they're comfortable with them. They do not like leaving the child alone. I had a mom who legitimately peed the bed because she did not want to leave the room when the child was undergoing cares, when the nurse was in the room. And so the nurse had to clean the whole bed because the mom peed in the bed. I mean, like, these moms do not want to let the kid be alone for fear that something is going to come out, or something is going to, that the child is going to accidentally divulge something. And in the education system, I've talked to school nurses and school administrators in some of this. And it turns out, I think this is kind of an untapped resource that we have, because often the schools are seeing signs even before medical providers might. Because think about it, it's kind of a mini separation test, because often the kids are there without their parent. So they're hearing one thing that the parent is reporting to them, and they're seeing something completely different. Because when you put a kid in a room of other kids, guess what? They want to be a kid. And so they'll not catch, that sounds terrible, but they'll see them doing things like wanting to use the potty, even though mom says, they need a diaper or whatever it is. They want to kind of be normal, or be just that kid that can be a kid. And they will split school professionals, school nurses, just like they'll split all of us. They'll split social workers from doctors. They're very keen in doing this. So the Sentinel case that I had at my hospital, I call it my case. I actually dreamt about her last night, which was so weird. I think it's because I was thinking about this so much, but her presentation was very much medical. It was the genetic, progressive, neurologic condition that only 200 people have, but she doesn't have the gene for it, but she has it. To the point of, epilepsy that's never captured on an EEG, but as soon as the EEG is taken off, it happens. It did not get to the point of actually inducing injury, but leave it to say she had the PICC line, the G-tube, she was in hospice care, right? The wheelchair bound, all of it. And her other thing was when she was about 5 years old, she was in special education, and the school system basically came to the caregivers and said, she's doing so well, she can go to mainstream school. And it was the parents who said, no, she can't. She needs all these special things. They said, well, we can't justify it anymore. We have other kids that need it more. They pulled her out of school and homeschooled her from that moment. And she actually taught herself to read because she wanted to be able to read the subtitles on anime movies. And so she taught herself how to read on YouTube. And at one point when I was in the room, it was really interesting. And amongst everything that was happening, she turned to her mom and just out of nowhere was like, Mom, remember when you told me I couldn't read? And I was like, And the mom was like, I didn't tell you that. And she said, yeah, you told me I couldn't read. And then I taught myself on YouTube. And it was kind of one of those moments where I was like, and in a way, I think it did help that case end how it did. I think the child was hitting that point of kind of, wait a minute, like some of this is not adding up. And I think she was already questioning some of it. And my newest case that has been kind of an active case at our hospital right now has gone down the medical path, but also down the site. So she sees a therapist at our hospital. And recently the case was accepted by our DCF for both neglect and medical child abuse. And I just read in a psychologist note from my facility, the quote, "This is not abuse or neglect. All I see here is a mom who cares about her child and is looking for a quick fix." And I was extremely heartbroken because that one sentence can derail everything. And we know that you can't just meeting the mom or just meeting the child once or twice, you can't diagnose or undiagnose this. That's not how it works. And I don't know how a quick fix is 3 abdominal surgeries in the course of 2 months, wheelchair bound, all of these things. How can that be a quick fix? Anyways, there was my soapbox for that one. But one of the things I want to point out that I think we are bad about as physicians, I'm realizing, is we all enjoy the people we work with. Like, I've stayed at my hospital so long because of my colleagues. We are not so great about communicating when the conversations are tough or when they're a little bit harder or when one person may feel like they're, being held accountable for something. The attorney I am close to that I know from the Kowalski case told me HIPAA actually covers continuity of care. So yes, you need to get consent from the parents to request records, but we can reach out to past and future providers on the grounds of continuity of care. So almost like passing the torch or passing the information. They don't have to choose to talk to you. They can say, I want a consent form before I talk to you. But the truth is, you can have that conversation. If you are able to, it can be eye-opening. Because of the transparency of medical records now, we are very nervous to write certain things in the chart. So even if we're not at the point of believing it's abuse, we are concerned by the behaviors, concerned by the patterns. We aren't so great about putting it in writing or putting it in on our documentation because we're scared. But if you can call that provider and kind of say, hey, I was kind of reading between the lines, but I noticed the last visit you had with them, this seemed to be escalating. This seemed to be a problem. Can you tell me more about that? Often you will get a good story when you ask for, do you know why the parent is now seeking care with us? Nemours, I was just telling Mira this morning, Nemours was the 3rd children's hospital in Orlando. So it was Arnold Palmer, it was Advent Health, which are very big names out in Orlando. And then Nemours came as the first freestanding children's hospital. I realize now that put us in a bit of a unique position in that we got the family showing up with the binder and saying the other 2 hospitals couldn't figure her out. Can you guys figure her out? And so I think we maybe were inundated a bit at the beginning with some of these cases. But when you ask why they actually moved to us, there's often a pretty good story. It's usually because you started to, like, someone at the hospital started to ask questions. Someone wanted to do an admission to prove why they truly needed TPN. Whatever that case may be, there's often more to the story than what might be in the chart. This is probably the hardest one for me. It's having those conversations with the people I work with every day. These are people whose kids come to my kids' birthday parties. These are people who live in my housing development where my husband is the HOA president. God bless. It makes things really complicated. But also, these are people I know. So it is a lot harder to call one of them up and be like, why did you do a third scope in the course of a month? Like, I don't understand. And, you know, it feels accusatory. It feels like, who's this hospitalist coming at me, a GI provider, and questioning, you know, my care? And it's an uncomfortable place to be. And these are very courageous conversations, I think. And that's why, to me, just opening up those lines of communication can go so far, because if it doesn't become an accusation, it becomes, we're all asking each other these questions. It just becomes kind of more the norm than the not the norm. And then I think, how many are hospitalists or general pediatricians, at least in the room? Oh, hi guys. I think we have both the benefit and the, I don't even know how to say it, like the cross to bear of, we see everything, right? We're not GI specialists who can do the scope, who can do the procedure, who can give those diagnoses, but we're the ones who kind of have to see a little bit of GI and a little bit of neuro and a little bit of this. So we kind of, in order for me to take care of a patient, I want to flip through the last note from each of the different specialties. And so I think it puts us in this unique position of sometimes identifying patterns where other people might miss them, because you kind of stay in, I don't want to know what the allergist, I don't need to know what the allergist or the ophthalmologist is doing, right? It's kind of, the hospitalist has to see a little bit of all of it. And I'm going to talk, actually, I'm going to bring up, so I had a case of a little, like, 2.5-year-old where I was already extremely concerned by the behavior of the mom. And there were, all the red flags were already present, and they had actually left a previous state because the older sister had been called in for medical child abuse. And so all the patterns were there, and I called it into DCF and the case was not accepted. And I'll be honest, life got busy. My kids were busy. I was on service. All these things happened, and I didn't check the chart. And when I checked it a month and a half later, they had gone to see our GI doctor, who in her note only reported what the mom said happened in the admission, not what the notes said, which was, we put a sitter in the room. The child did not vomit once. She ate everything by mouth. She did not use her G-tube. She pooped on the potty. She did not need any constipation medications. And she wrote, mom reports in the hospitalization, the baby vomited every day, despite the fact that she didn't take enough calories. Dr. Gill said she doesn't need to use her G-tube. And so mom was requesting to go to another hospital. Within a month and a half, she had an ostomy. She had part of her bowel resected at 2.5. So I will carry that with me, because I feel like I didn't do enough. And I know that's a fault of the whole system. I understand that. But, like, for me, that feels like a failure. And it still, like, scars me to this day. And I wish I had looked, because at least I could have called. Maybe they wouldn't have listened. To be honest, they had my records. They said reviewed Nemours Children's Hospital records. So if they did, then how did they not read that? And so that thought that we can, at least, again, they don't have to talk to you, but if they do, you don't have to call and say, hey, this mom is totally suspicious. Like, but you can call and say, look, I want to let you know where we were in the process, you know, what the last admission looked like, that we did call it in and it wasn't accepted, whatever, things that maybe you're just saying, please be aware, like, keep your eyes open. I just reached out in that most recent case I was talking about to a colleague that used to work with us, who now is at another children's hospital in Orlando. And I reached out and said, hey, if you guys want any information, I'd be happy to talk to whoever the hospitalist is taking care of them. And they didn't ever respond to me. And again, it's this, nobody wants to talk. And I don't know how to do better other than to say, I did talk to Banner Health last year. So maybe even if you reach out, maybe they'll be a little bit more open to talking. I recently, are you guys familiar with the Gypsy Rose case? That's the one that obviously is out in the media the most. So I was rewatching Mommy, Dead and Dearest, which is the documentary about her case. And now I'm watching it with these like new eyes of everything I do. And I'm like, oh my God. And so it was like watching it completely differently. Mark Feldman, who's like the grandfather of all of this work, is in the documentary. And I'm like, oh my God, I know him. So it's just, it was so weird watching it now. And in the background of the documentary are notes from her neurologist. And I like now pause the screen and like blow it up and try to read what the notes say. And it was interesting because he said all the right things. He said the physical exam findings that didn't line up. He said, despite mom saying she hasn't walked in this long, her muscle mass is normal in her lower extremities, right? Like you could read his exam and know what he was saying. Mom immediately came in the office and told me how she has muscular dystrophy, this. And then he says, however, I spoke with her previous PCP who told me she does not have muscular dystrophy. Her muscle biopsies were normal. Her genetic testing was normal. This patient does not have muscular dystrophy. And I was like, amazing. He reached out to the previous provider. He got information. He puts in his assessment. I suspect Munchausen by proxy, and I'm concerned for this and this. Or maybe it's a rare genetic condition that we haven't yet identified. And I'm just like, oh. And then he said, we'll proceed with EMG and neuromuscular testing, you know, so it's like, we still can't say it, right? Like we still have this need to do more, do the next test. And then at the end, he's interviewed and they say, so why didn't you call anyone? Like, why didn't you do anything? And he said, well, everybody at the hospital was just such a fan of this mom. Everybody supported her. And to be honest, if I was just going to be the one voice, I would have been rejected in a heartbeat. And I was like, it's so interesting to hear it now and think that that's really how a lot of us feel. Like, why am I the only one seeing it when you probably aren't? You just might have been the only one willing to write it. But that one really struck me because she was 9 years old, I believe, at the time she saw that neurologist. And when you think of how that story ends, it's like, what if something had been done then? I think we all work in silos. It's because we have to see so many patients in a day. It's because we have to get our work done. It's because we want to go home and get to our kids, right? There are reasons we do it that are not self-serving. It's just the way the world works sometimes. That being said, I think San Diego Rady's Children's, this is their article. At the end, I'll have links to all of the articles that I talk about. But they've created, your hospital, I know, this is what's coming for you guys. And I am so jealous because we don't have this yet, despite my many efforts, of a multidisciplinary task force. The biggest things that I noticed in reading about this and in talking to the people at Rady's who do this is they really had administration buy-in. And just the fact that I'm here these couple days, I think speaks volumes that your administration is considering this and willing to talk about it. But if you don't have that, it's going to be really hard to get people to come to these meetings and talk about patients because surgery will say we're in a surgery. Someone will say, oh, I got stuck in clinic, right? And nobody will come. And that's kind of how I see it if it happened at my hospital. But the amazing thing about this is any concerned staff member can refer a case to the task force. And this is where I struggle a lot because my nurses take care of kids on the surgery service, the ortho service, like not just the hospice patients. And because they know me now, they'll be like, Dr. Gill, can I run something by you? And I'm always like, ugh. And they'll say to me, I have such big concerns about this. And I'm like, technically, like I'm not supposed to know, right? Like I'm not seeing this patient. So I want somewhere that I can tell them they can go, that's different than just telling the charge nurse every time or, feeling like they are the only ones seeing it. And so it's a tough place to be. But the idea that any concerned staff member can refer a patient to this task force, and then they do a very brief overview of the chart. So they're not going to go digging. They're not going to go search for charts from birth if they're not already in the chart. We do have the benefit of having Epic. I'm going to caveat that we have Care Everywhere, which is an opt-in. So like if you sign our consent at the time of admission, you are consenting to Care Everywhere, meaning I can access any records in the Epic system that are there. It is an opt-out to not do that. And I always find it interesting. It takes like going to medical records, signing extra forms, explaining why you want to opt out of the medical records share, to me, if you're going to go through all of that, like, I want to know why. Why would you not want the doctors taking care of your child to see what happened before? And so again, they would just review what's there and they'll decide what the next step needs to be. So it could be as simple as, we're going to put a flag in the chart just so future providers know there's been some overutilization of healthcare. It may be they reach out to the one provider who seems to be struggling with like conversations with the family, or it may be to the point it's already so far that they need to call DCF or DCS immediately. And then the big thing that they do is they have this team meeting where they bring every specialist who is caring for that child together in a room, and they talk about it, and they come up with a cohesive plan with all the specialists. And I said to my friends at Rady's, I was like, is it the same people always? Like the same GI, the same surgeon, the same allergist, whatever? And they're like, there are patterns, you know? And I'm like, and I said, but don't they feel like they're being singled out? And they said, honestly, I think they finally feel like, I knew something wasn't like I knew, but once you get into the it's hard to get out of it. And so hearing other people say they were struggling also with these families actually allowed that communication to happen and kind of made them feel stronger, made them feel like they had a backbone, because if they went in and said, we're not doing another scope, they knew they weren't going to go see another doctor who was going to say we are. So it was kind of, at least if we keep them in the institution and we identify them earlier, it's going to benefit the child. And that's where I think a lot of our work is how can we stop it from being that sentinel case or that worst case? And this is one of the places I think we can. What they found and their outcomes, which I think were so, this is like where I'm like, please, Nemours, do this, is this idea that every time you sat in one of these task force meetings, people came out of it saying, I understand a little bit more why people are concerned about this. Or they could go back to their specialty and say, hey guys, I went to this meeting, we were talking about this, and it caused policies to be changed. Things like, in order to pursue a G-tube at Seattle Children's, you have to go, there is a checklist and every patient goes through the checklist. It's not, you can't circumvent the checklist. It happens for every kid with the G-tube. And they have been identifying things sooner before it gets to the point of the child being harmed and able to actually intervene on that anxious mom that maybe is down the wrong path. And they feel empowered. They feel like they can go back and face these parents with a little bit more strength and a little more confidence because everyone's doing it. The reason I'm here today, I think, is really because I want people to know about this, and I want people to know it is not easy. I'm not standing up here saying I do this perfectly, clearly, by the case I shared with you. But all professions need this training. So the DCF system needs it. Lawyers who are in family court need to understand this abuse. Judges, right? Like everybody, law enforcement and SVU needs to understand this. Schools need to understand this. So this idea that we go and we talk to all the different groups, but then I think getting everyone in the same room is monumental to this. When you start hearing shared experiences, a case that everyone shared, that you can say everybody was affected morally, ethically by the case, it really opens people's eyes, I think, to how hard this is on everyone. It's not DCS trying to be difficult. It's DCS fearful for what could happen to them, right? It's they don't have the resources for this. And so when you actually get people in a room, it goes so far. And if you can know people in these different systems, I wish I had, like, I know our CAP in Orange County, but I don't have that one, law enforcement or DCF worker. Of course, I see the same names come up. So I'll get someone on the hotline when I call in a case and they're like, oh, so what you're saying is it really sounds like Munchausen by proxy, but also there's medical neglect because they aren't treating the things that the child actually has. And I'm like, yes. What is your name? What is your, because I'm like, they're listening, like they're hearing it, and that sometimes feels rare. So when my sentinel case happened at my hospital, we did an M&M, so like a morbidity mortality conference to talk about the things that went wrong. But that case was a success. She is going to be 18. She's in foster care. She's thriving. She has a job. She comes back to the hospital and hugs all of us. She's doing all the things we wanted her to be able to do. So it was kind of this success story that we got to talk about of how well she's doing. But we really didn't dig deeper into why this case got where it was and why, like, what we could have done better, because we have now had other cases that have gone the same way, you know, different ways. So I realized what we should have done was like a root cause analysis and go back and say, how did we even get here? And I think that's how you dig deeper. And that's what Rady's did that got them into the task force. Sadly, I think the case I'm dealing with right now probably is going to be the one that is the root cause analysis, because almost every single specialty at my hospital has touched this child. And so it would force everybody to have, you know, the tough discussions. And then I just was giving a talk in Florida where a nurse practitioner from DCF came up to me and said she was involved in the Sentinel case. And she said, it is so interesting to hear you talk about it from your perspective, because she said, we were all struggling too. Like, we were having meetings saying, what are we going to do? Like, we don't have enough resources to help. And so it was so eye-opening for me when I was like, I felt like I was beating my head against a wall to hear that they were struggling too. In this case, one of the DCF workers told the child, I would be letting you go home to your parents, but the doctors aren't letting me. And so all the rapport I had built with the child, everything we had worked towards was broken that day. I walked into a kid who was screaming at me, telling me she hated me, all of these things. And in a way, I kind of had to be the villain that day. And it was really hard for me. Someone who did this because I want to help the kids and I want to be like that person for them in a lot of ways. It hurt. It was hard. And so I realized, even if we're going to have things outside of the room that we disagree on, that we need to talk about, those courageous conversations, they shouldn't be happening inside the room. And they shouldn't be like, it can't be one going in and saying one thing, one going in and saying another, because it breaks immediately when that happens. So anytime as a hospitalist, you can go in with that provider, it's going to go a long way. And that is hard to do. We are all extremely busy, but I promise, like, the benefits it will reach to just show that you're a unified front. I went in, I feel bad. I keep throwing GI under the bus, but let's be honest, GI, like, there's a lot of GI in these cases. I'm sorry. I love you. I couldn't do what you do, but they love you guys. I mean, they do. But I think, you know, I went in with one of my GI providers and all I told him was, I'm like, okay, the one thing we are not going to lead with, we think you're a great mom. We're going to start with, we are concerned about this and this. We are not going to proceed with this and this. We're going to do it. And he's like, we're going to do it. I'm like, okay. And so we walk in and the mom immediately, like, tears in her eyes, oh, I'm so glad you're here. Not to me, to him. And said, I'm so glad you're here. I knew you would come and you would understand. And he goes, Mom, you know, we think you're a great mom. Like, 10 seconds, come on. And so I had to step in and be like, actually, what we were going to say. But to be honest, one of the things in the Kowalski case is Sally Smith, who was the CAP that was involved in this case, was really, it was sad. I have been to her home. I've spoken with her. She is just heartbroken over this case. She had threats to her home, her grandchildren. Her pediatric practice had every morning messages on the answering machine saying someone was going to come and shoot up the practice. Someone was going to come and burn it to the ground. Like, this is not benign. One of my friends in San Diego at the last conference said to me, how have you never been sued? And I was like, wow, thanks for that, now that that's out in the universe. But truthfully, when you do this work, it is a real fear. But that's why I think the more we can do this as teams, the more we can be a unified front. It is going to be semi-protective, at least, of things going that far. When you are reviewing the charts, if you are a hospitalist and maybe you have 10 minutes while your residents are, you know, running around seeing all their patients, if you can do even a brief review of things, just look back to those last couple notes. Again, the benefit of Epic or Care Everywhere is I can search something like tube or NG tube, and I can go back to the first time it was ever mentioned, at least in like the Epic chart. I can put vomiting and see like the first time the child presented with vomiting, albeit there may be records that aren't there, but like, it's pretty telling. Sometimes you can get all the way back to their birth records and realize how far we've gone from that, or where it all started. I like searching for language. I'll put in things like mom demands into the search thing, or, mom reports even, and it'll be, despite normal this, and this, mom reporting this will proceed with this, right? It's like that language that you see time and time again. The things we are working on to let you guys know that, like, systems wide, we're trying to do better is really finding objective language, objective data that we can use, because this is still a hard kind of abuse to report, to kind of show the harm, because there's not as much, it's not like this tangible thing that you can show someone so much. To me, an abdomen with scars all over it and scars from to me that is, but that's still harder to explain to someone. And so that's really where we're working. In one of my cases where it was actually like a baby, more of like a 2-year-old, a toddler who had a GJ tube, I went back and put tube in Care Everywhere. And the very first note that came up was, mom is asking about whether the child needs a tube. And in reading the history at that time, it was a 3-month-old with reflux and colic. I had a 3-month-old with reflux and colic. I was like, just make him stop crying, please. I was not saying, does he need a tube, right? It just was already an odd thing to me. Then there was a sentence, it said, mom does not want an NG tube at this time. And I was like, I was wrong, comma. She states, quote, if he needs a tube, I want him to get a GJ tube, unquote. 3 months old with reflux. Who says that, right? I read that sentence and I'm like, that sentence, that's all I need. Like, I don't know what to say, but to me, that was such a red flag. And the fact that the doctor wrote it like that meant they knew it was a red flag. Do you know what that baby had 8 weeks later? A GJ tube. So when we are writing about this, I understand why transparency of the medical record has to happen. I think in pediatrics, we are in a unique position, because what if the person reading it is the perpetrator of some form of abuse, specifically this type of abuse? So how can we document for other providers? You need to know your institution's blocking policies. Do you have notes that are truly blocked, or notes that the parent can still request after the fact? Is it they will be released only in the case of a court of law or DCF investigation? You need to know that, because it turns out my hospital, what I thought I knew, I did not know. And so again, it's important to know what your hospital allows. I think when you're documenting, think of it in these kind of 3 ways. Think of, how is the child being harmed? If they are not yet truly, like, they have not had multiple procedures, they've not had a tube shoved down their nose 20 times, whatever it is, that's amazing, because you may still be in the early stages. But think of things like that sick child persona. Like, that kid believes they're sick. My patient looked at me and said, but I don't understand. Like, I've had this my whole life. And it's like, I know. And when I heard that one of my GI providers went to a conference and met one of their previous GI providers and said, we have one of your kids now, and mentioned it, that doctor said, oh, the Munchausen case. And my provider said, yeah, the Munchausen case. What did you guys do? And he said, well, at that point he was already moving to Florida. So we figured, and that I hear more than not. And that's so hard for me. But think of the scars. Think of the fact that every time you open that bowel, it is now a stricture or a scar or something that can cause further damage down the line. And just the fact that these kids, it's really hard for them. We equate it, I keep saying this but like, we think it's more like sexual abuse, in the sense of that entwining of caregiver and child, that we're not going to tell the truth today. We're going to say this, but understand we're doing it so you can be safe. It's, mommy's going to have to tell some stories that aren't true today, but I want you to know I'm doing it because I love you, because I don't want you to die. That attachment is so pathologic and so harming to these children. When you recognize behaviors, I'm going to talk to nursing administration after this. Nurses see things we don't. So them recognizing the behaviors, I think, can be so helpful. They may see something that the mom would never let happen when we're in the room. right? The child knows to not talk when the doctor is there. Gypsy Rose, actually, one of the things I did learn from her case was she said her mom, all she would have to do is like squeeze her hand or even just like eye contact. And Gypsy knew that meant stop talking. And so I've now watched for those like nonverbal cues from parents. The recent case I'm involved in right now, I was, mom, it was like, she needs Carafate for her gastritis. Well, she can't take the liquid. It's too much volume. Well, she just guzzled a Gatorade. So maybe we could try again. Well, no, she can't do it. Okay, well, then she can take the pill. The pill's too big. Can we cut it in fourths? Yes, we'll cut it in fourths. But then it's still hard for her to swallow. Okay, but she takes all of her other medicines by mouth. Well, and amazingly, you have a G tube. So let's put it through the G tube. No, it causes pain. I was just like, Mom, like, you make it impossible. Because then her next sentence was, I think she probably needs another scope to see if the gastritis has progressed. Of course the gastritis has progressed. You haven't given any of the treatments. And so again, it's like they make it impossible, but even documenting those things, that does show that pattern, right? Of these behaviors that we all know are there. And then I think in Florida, medical child abuse is not an automatic referral to the CPT or our medical team, but medical neglect is. So if you can also put in your report the things that are being neglected, it can go a long way. So I can say they're neglected from going to school, meeting their potential, getting their gastritis treated, whatever it is, but there's also neglect. I'm going to throw this on your institution that I think the better our institutions are about taking a stand. I wish the AAP would come out and say, we know this abuse exists. We're going to be talking to each other. We're going to be communicating. We as pediatricians need to do better. I don't know how your bonus structure works, but often bonus structures are based on RVUs, are based on, number of this, number of that, number of patients seen in a day. The thing is, it is open access to providers. They can send you 100 messages. Eventually, you just say yes, because you can't take another message. And I understand that. I don't do outpatient, but I look at the number of messages and I am overwhelmed immediately. My inbox is one of those like 22,385 or whatever on Gmail. So like that would overwhelm me completely with the numbers. So I understand yes is often the easier pathway. So I think bonus structures need to be changed. That is probably speaking out of turn. But I think we need to do better and all of our organizations need to do better. I don't know if you guys are aware, but the Kowalski case, which was a $250 million verdict against Johns Hopkins All Children's for them reporting medical child abuse in October of last year, was reversed completely. That did not make the cover of People magazine. So it was reversed. It stands at 0. There are a couple counts that still are out there that could come back, but they are minimal compared to the ones that went before. And so that is huge. I am lucky because I'm lucky because I live in Florida. Wow, words I never thought I would say. But it is precedent setting in Florida now. It is persuasive in other states, but it is now a precedent in my state. So that is and feels a little bit more protective. These last 2 slides, I'm going to say are to me the most important. We did a lot of school to be here, right? We did undergrad, medical school. A lot of us had jobs elsewhere. We did residencies. We did fellowships. We know what we do, right? So why are we breaking our standard of care for maybe not one patient, but one parent? If you tell me a child can tolerate 400 mLs an hour of Go Lightly through their tube, but the second you put 5 mLs of Pedialyte, they scream in pain, that does not make sense, right? We know this. And so that idea of why are we doing this? Like we did this for a reason. And honestly, you are helping the child, I promise, by following a standard of care. If you would watch and wait for another kid, if you would say, this needs 3 weeks to see if it's going to work, barring some terrible side effect, which sometimes they have as well. Don't change in 2 days. Give it the 3 weeks. Just say no. My colleague, Dr. No, I present with her on this topic, and her last name is No, NGO. So this is my whole thing. I'm like, V, we are going to go big at the hospital. It's going to be called Just Say No. You're going to go. You're going to talk to people. I'm like, it's brilliant. But really, If you have all 5-star reviews I was going to say GI again. Oh my goodness. If you are a specialist with all 5-star reviews, you've never said no. So that has to be something you kind of process or try to figure out how you're going to do it. And I think that reviewing the chart as much as you are able, again, Epic does make my life much easier. But if there is any way that you as a provider can step back even one step for these children, it could go a very long way. And I was just telling Mira, a lot of dads whose children are victims of this abuse. And it is dads, I'm not going to lie, but like where the mom was the perpetrator. And these dads were never involved in the conversations. The child is on their insurance, but they aren't involved in these big decisions because only one parent has to sign a consent. I had the case I was talking about with the one who said if he needs a tube, he needs a GJ tube. I was in the room with that family. They had transferred care to our hospital. And I said, mom and dad were both in the room. And the dad I said, wow, he is running around here. He looks so good. Like you would think this was a kid who could eat. And the dad goes, oh, he ate his sister's Pringles yesterday. And I was like, and that mom sent that dad daggers like you would not believe. And the dad's like, what? He did. And the little girl goes, he did. And I was like, huh. So I look at the mom and I was like, that's wonderful. I mean, if he can eat Pringle, like, isn't that amazing? She's like, dad doesn't know what he's talking about. And I was like, okay. And she said, he can't eat. I'm like, okay, but I mean, he did, right? I mean, again, wouldn't it be amazing if he doesn't need to eat through the tube and he could eat by mouth? And wouldn't it be amazing if at least you knew when he stole his sister's Pringles that it was safe? So I'd like to redo a swallow study that he hasn't had, in a year and a half. Mom immediately breaks into tears and says, you won't do that to my child. You won't cause him that pain. I won't consent to it. And I said, Mom, he's had 3 GJ tube revisions in the last 2 months. Like that's anesthesia. That's all the things. And she's like, but he doesn't have to feel pain. I'm like, Mom, if he feels pain, we would abort this. Like if he's not able to do it, we would stop the study, but at least we would know. She said, no, I won't consent to it. And the dad's like, and he looks at me and he's like, no, we want the study. And the mom's like, no, we don't. And I was like, oh no. So anyways, we had come to the conclusion we were going to do the study the next day. Sadly, I went off service and they didn't do the study and they left AMA and it was a whole thing. But DCF was contacted. And I recently looked in the chart. Mom has sought care elsewhere. From that day, care everywhere was blocked, so we couldn't see previous notes. But the dad and mom are now separated/divorced. I feel slightly responsible. That being said, I think it might be the best thing that ever happened to this child because the dad has been reaching out to Nemours and saying, when I have my son, can I bring him to you? Because you are the only ones who were willing to try again, like to start back at the beginning. And so I feel like that dad being a part of that conversation probably made a huge difference. And he at least heard. This is what I've really lately with our teenage patients, with the ones who have completely encompassed this role of the sick role. It's hard to even know where it all started sometimes, and they can be extremely frustrating. I have started to really take at least a moment when I'm in the room, because again, the parent's not going to let me have time alone with them, but where I look at the child and I say, I want you to listen to me. And I say, I know you hate me. I know you think all these things, whatever. I said, that's okay with me, because I also want you to hear that I want you to get better. And I said, if you came back in a couple years, walking out of your wheelchair, going to college, having a job, whatever, and you come in to tell all of us that, I said, I would have tears in my eyes. And I can tell you, because it's happened to me with that patient I talked about. Every time I see her, I can't help it. Like my eyes just fill with the thought of where she was. And so I tell them, I just want you to know there is a doctor who wants you to get better and who really thinks you can. And I will say it in front of the mom and in front of the child. Often the mom comes back and no longer wants to see Dr. Gill, But I always find it interesting. Like, why wouldn't you want to see me? Like, why? I mean, why? I didn't do anything different other than telling your child, I think they can be better or get better. And anytime, I had a mom write me up or send to administration for talking about treatment options in front of the child, because the treatment options involving a therapist or having the child have someone to talk to. And she said she had the audacity to call my child crazy and say she needs a psychologist. What I actually said was, and I confirmed with the residents who were with me, because I'm like, oh my God, was I on one of my rants? And I said the wrong thing, but they said, no, you looked the girl in the eye and said, I do not think you're crazy. I think you're going through a lot of things and you need someone who is your outlet that you can talk to. And so again, I think just having, honestly, a teenage patient, I think having the conversation outside of the room is more inappropriate than having the conversation in front of the child, because I think they have a right to hear your concerns. And I always say, if you ever have questions, if you ever decide, that you feel like you're not being heard or whatever, I'm here. You can find me. I'll be here. And I've done this and I have been the villain. It's been hard on my psyche, I think, a lot. But I've actually had residents say to me, but what is wrong about that? Like, what is wrong about telling the child you want them to get better or to function or to be as healthy as they can be? So I'm going to leave you with this idea of kind of, if you haven't yet had that sentinel case, do the task force, do what you guys are doing, open communication. If you start seeing signs, talk about them, be a unified front, talk to each other and document all those warning signs. If it's already too far gone, try to get some timelines together, document your concerns and call it in. I know social work, I think, calls it in at your institution, but that needs to be the conversation. And then after, if you do have that sentinel case, I highly recommend doing some kind of a root cause analysis so you can be better the next time. This is my friend, Michelle. Her sister and brother were victims of Munchausen by proxy abuse. Her brother actually passed away from the abuse. And she has changed my life, hearing her story and knowing her now like I do. So she wanted, and I wanted to share words. Oh, nope, just kidding. Hold on. Okay. And then I need to use this, right?
Hello, my name is Michelle. And first I want to take a minute to thank you guys for listening, for wanting to learn, for doing your part in preventing medical child abuse. Medical child abuse is something that's kind of haunted my family for years. My siblings were both medically abused by our mother. The difference between their two cases is, in my sister's case, she had some wonderful NICU nurses and hospitalists that would not back down. They saw what was going on. They saw things weren't right. They made reports. They did everything in their power to keep my sister safe and ultimately saved her life. Unfortunately, that didn't happen with my brother. My brother didn't have anybody in his corner looking out for him. They saw my mother as how she presented, which was a very caring, loving, devoted mother who advocated for her sick child. And because nobody saw past that, nobody reported, and my brother ultimately lost his life. The way I process things is getting all the information I can. So I have spent years learning and educating and connecting with others and learning everything I honestly can about medical child abuse and what it looks like and what it is, to try and get some answers into my own life and the life of my siblings, and ultimately the death of my sibling. And on that path, I have met some pretty amazing hospitalists like Dr. Gill and some pretty amazing experts in this field. And I can say that one of the things I have learned is how incredibly difficult of a decision it is to report a mom for hurting her kid. It is complex and it's confusing, and it doesn't make a lot of sense to a lot of people, especially when you have moms like my mom who look so charming and so caring and so loving. I'm sure it is probably one of the most difficult parts of your job to have to make a report on a mom like that. where you go home at night and you're second guessing if you did the right thing or the wrong thing. What I can say is that oftentimes, more often than not, honestly, there is a child. Maybe it's a sibling, maybe it's the child that is thanking you, that is laying in their bed at night and thanking you for caring and thanking you for not giving up. And I still have a relationship and will always care deeply and be so incredibly grateful for the nurses in my sister's case that truly saved her life. And I will always wish that there had been just that one nurse that could have intervened and saved my brothers.
So I am going to pass it. We can put this up at the end again, but this is to get access to all the different articles. And then I think Mira's just going to share with you where you guys are in all of this.
Awesome, guys. Hopefully that resonated with everybody and you guys were able to learn a lot, and hopefully our GI colleagues aren't feeling too butthurt about the attacks. But just to let you know, there is a medical child advocacy task force that has been formed here. It's a multidisciplinary team that's dedicated to identification, assessment, initial management, and reporting for all these cases. How to report your concerns. There's a smart sheet, an index that's coming soon. You could always just email or Teams the people that are within the task force. It's led by our fearless hospitalists, so Dr. Kelly Kelleher, Dr. Nima Desai, Dr. Bo Forsch Christensen, and then our social worker turned lawyer, Elena Rates. So you could contact them directly or look for the smart sheet and index coming soon. Thank you all.